Well, we're delighted at Health for the World to welcome Dr. Brian Englander, who's the chairman of the Department of Radiology at the Pennsylvania Hospital at the University of Pennsylvania. And his topic today is on breast cancer. And I'd like to introduce our Health for the World moderator. Why don't you go ahead and introduce yourself and introduce Dr. Englander. Thank you.
Hello, everyone. My name is Aditi Chaurasia, and I'm a postdoc fellow at NIH. I've been working for Health for the World for the past 1.5 years, and I'm delighted to welcome Dr. Englander. He's the chair of the Department of Radiology at Pennsylvania Hospital, and he's an expert in the field of breast imaging and intervention and has been actively involved in global health projects. He's been working in several different countries for outreach, such as Mongolia, Israel, Haiti, Romania, Sri Lanka, Vietnam, Egypt, and many more. I would like Dr. Englander, I would want to welcome Dr. Englander, and the floor is all yours.
Thank you so much. Thank you for the invitation, and hello everyone, whether it's good morning or good afternoon or good evening. So it's my pleasure to be here and to discuss, sort of the topic that I guess I've been most involved with for my career, which is breast cancer, and understanding the global scale of diagnosing and managing breast cancer from sort of an overall perspective, but really from sort of my subspecialty, which is radiology, or radiologist perspective of this issue. So just a quick background of sort of what I've been involved with breast cancer and other things. As was mentioned, I've sort of been working sort of throughout different countries and different aspects, from Vietnam to Rwanda, and sort of countries, I think on most continents at this point, doing breast work, doing education work, building curriculum, as well as I think my most recent project, which is completely off topic here, is working on replacing pit toilets with standard toilets throughout Mongolia. Is sort of the current initiative that we are sort of taking on as well. We had started prior to COVID doing conferences internationally. The first was in Tel Aviv, and the plan was to go to multiple different countries. The idea being sort of bringing knowledge, much like what is being done now, to different places of the world, and sort of understanding what the needs are, and not just sort of replicating each conference as the same thing, but really, what is best to bring to populations, and at no cost to the folks who are in those countries. And also, have a number of programs of bringing people from abroad to Philadelphia to speak and share with our residents at Penn as well. So we are tentatively hoping to be in Columbia in the spring of 2024 and beyond. So background for breast cancer. So breast cancer is a massive sort of impact on the world as a disease, as a non-communicable disease. About 2.3 million women are diagnosed globally with breast cancer, and just shy of 700,000 deaths in the most, 2020 in the GloboCan research. Right now, there are about 8 million women alive who've been diagnosed with breast cancer within the past 5 years. And in 2020, it became globally the most prevalent breast cancer. So it was a shift from, other cancers that had sort of, given the fact that this really predominantly affects women. So it shows you just the huge impact. And also within that, there's the most lost disability adjusted lives globally. So it's just a huge impact in that respect of, women who are getting breast cancer, mothers, often throughout the world, the maternal impact of caring for the family, providing for the family, not just at home, but even outside of the home, like in Haiti is a good example, where money is made by women in many families. So it's how do we deal with this is a question. And another issue is, and I think this is probably an underestimation, but in transitioning countries, there's nearly a 20% higher mortality rate for breast cancer. So just giving you a very colorful map, and I think if you look at the top two images of the world, that's for the incidence and the mortality for men. In the bottom, you're seeing the incidence on the left for women and the mortality for women. And of course, breast cancer is defined by its pink color. So it's overwhelming in terms of incidence globally. The only thing that probably really the only thing that's sort of hitting it beyond is you have liver cancer in different parts of the world, like Mongolia, parts of Africa, but really everything else is, it's the highest in its incidence is breast cancer. Mortality right now, it's also, in most of the world, other than perhaps Western Europe, North America, and Australia and New Zealand, it's also the highest mortality. So it really is a big issue that we need to address, and how do we address it, and how do we, I guess, from my perspective, find breast cancer to address. So, where we are now. So this is looking at the high sort of human development countries, elevated incidence rates. There's a higher prevalence of reproductive and hormonal risk factors leading to this, early age of menarche, later age of menopause, often an advanced age of first birth, and a fewer number of children, and all of these things where they reversed, create a lower incidence of breast cancer. There's less breastfeeding, often in the developed countries, and also, higher use of menopausal hormone therapy and oral contraceptives. Lifestyle risk factors, and these are, I think, well accepted risk factors, is, the alcohol intake, excess body weight, and physical inactivity in many of these countries leads to a higher risk of breast cancer as well. I think the other major thing is, radiology's impact of having either organized or opportunistic mammographic screening. We just find more breast cancer at earlier and later stages. And then in certain countries, North America, Israel is a good example of a high prevalence of mutations, genetic mutations, specifically sort of the most commonly known ones are BRCA1 and BRCA2. So where are we going? Despite, relative decreases in, breast cancer mortality and whatnot in the U.S., there's been a slow upturn in incidence rates in the United States since 2007, less than about 0.5% or less than 0.5% annually. Moderate but significant increases in many countries throughout Europe and Oceania. And the incidences are rising fast in transitioning countries like South America, throughout Asia and Africa. And then particularly in the high-income Asian countries, in Korea, the rates had been historically low. My work in Mongolia sort of was triggered by the fact that there was a very low rate of breast cancer, and it really wasn't a huge concern because of the low rate. But the incidence is rising quite rapidly throughout much of Asia as well. Why is this happening, I guess? And these are not absolute answers, but sort of thoughts and some research showing them to be true, is there's just changes in lifestyle, sociocultural, and the environments, postponement of having children early, having fewer children, excess body weight, physical inactivity, all of what has led to high rates of breast cancer in the West are now converging in the rest of the world. Sharing our love for fast food throughout the world that the West has always had is sort of contributing to this as well. And it's, there's also narrowing international gaps in the morbidity for breast cancer as well. Giving you an idea once again on incidence and mortality, you can see that the incidence is much higher in Australia, Western Europe, North America, much lower in other parts, and the mortality varies, but generally tends to be higher in Africa and in parts of Asia relative to Australia and the countries where it has the highest incidence of breast cancer. So sort of focusing a little bit on Africa. In Africa, there tend to be low survival rates in sub-Saharan Africa. That is largely attributed to the fact that these present at late stages. About 3/4 or more of all stage cases in Africa or sub-Saharan Africa are stage 3 and stage 4. So presenting that way, the morbidity certainly, and also the mortality is going to be markedly increased. In Africa, there tends not to be organized population-based mammography screening. In the United States, we have a very strong national screening program, Western Europe as well, particularly in Scandinavia. They sort of have been kind of the originators of this population-based screening. So cancers are just found later. They're not found at sort of the much more treatable stage. And these screening programs have not been up to now cost effective or feasible in low resource settings. We have to sort of figure out, what resources are available, what money is available, and what's like, how can we do this? And my hope, when I started doing this work a number of years ago, was placing mammography throughout the world and making that a reality that we should all have screening programs, or if not screening, at least access to screening should a patient want that. But it's obviously a much more difficult project than just sort of that hope. So there have been efforts to promote early detection, improving just awareness of breast cancer as something that women can get, whether it's in the United States or in Vietnam. The idea is, well, I don't know anyone with breast cancer. My mother didn't have breast cancer. My grandmother didn't. So I, in all likelihood, don't think I'll have it. But the fact is, we know that the vast majority of breast cancers develop in women who have no family history. And then also to promote clinical breast examination by skilled health professionals. And I will touch on a device that I've been involved with developing, and not developing, but being a part of some of the research efforts that can take some of the work out of skilled health professionals, because a clinical breast exam, to teach it, to do it right, is time consuming, and most people don't do a great breast examination by their healthcare provider, and certainly self-examination have been very, very controversial, whether or not that shows any cancers. And we know it does, but I think just from a population base, I think that it's not necessarily the best test that we have, but certainly better than nothing if that's all one has. The next thing is timely and appropriate treatment. Like, even if I were to place a mammogram and an ultrasound into every city and town and village in the world, can we actually treat what we find? Do we have the correct therapeutics? Do we have surgeons if it needs surgery? Do we have radiation if that's what's appropriate? Do we have hormone therapy or chemotherapy? And I think that's a project that our oncologist and other colleagues in the medical fields are working very much to make an impact on. There's been an estimation, I think this came out of the World Health Organization, that 28 to 37% of breast cancer deaths could be prevented with earlier diagnosis of symptomatic disease and appropriate treatment. So that's a big number. It's a big number just as a statistic, but if you're thinking about the number of breast cancer diagnoses we make each year globally, it's an enormous number. And there was a sort of suggestion by the World Health Organization that if we could somehow reduce by 2.5%, then we could by 2040 avoid 2.5 million deaths in women that should not die from breast cancer. So once again, these rapid increases in sub-Saharan Africa between the mid-90s and the mid-2010s, greater than 5% per year in a number of countries, in particular Nigeria, Malawi, and the Seychelles, 3 to 4% per year in South Africa and Zimbabwe. These are high increased numbers. And simultaneously, the mortality rates are increasing just as quickly, and they are now among the highest in the world. And this has to do with in parts of those countries, a weak health infrastructure, and as a result, poor survival outcomes. The 5-year survival rate in 12 sub-Saharan African countries was sort of measured, and 66% for cases diagnosed during 2008 through 2015, and lower, 20% to 60% in South Africa, Kenya, and Zimbabwe in particular served towns. They obviously didn't do this as a national effort. It was village and town controlled for the analysis. So now we are sort of, I've given some background and a little bit of focus on Africa. So, what challenges do we have? And, the challenges are many and great, but certainly not insurmountable. So there's a challenge of establishing primary prevention programs for breast cancer, improving our health in the world. efforts to decrease, excess body weight, to decrease alcohol consumption, to encourage physical activity, not just exercise, but just, daily physical activity, and also to encourage breastfeeding throughout the world. Whether or not we consider developing population-wide breast cancer screening programs. Early detection is key, and that's sort of a mantra of the American Cancer Society and other societies in the United States, but we know that to be true. And sort of developing and disseminating effective treatments. So the World Health Organization, they suggest that mammography should be every 2 years for women at average risk for breast cancer starting at age 50 to age 69. This is vastly different from what the United States suggests, whether it's the American College of Radiology that we start at age 40 yearly, but this is, sort of looking at the number of women that we need to screen, and this, has been proven to be a significant impact on reducing mortality and morbidity and finding breast cancers earlier. We know about the limitations of mammography. We talk about them often. The big one we talk about is overdiagnosis. I'm not a big fan of that word. I think most of us aren't big fans of that word. We feel like there's probably adequate, sort of appropriate diagnosis and overtreatment. I don't think overtreatment in a global sense is going to be the problem because of just lack of access to treatment options. We need to improve the cost effectiveness and sort of understand and address the benefit to harm ratio of screening, of unnecessary callbacks, of unnecessary biopsies, or not unnecessary, but biopsies that yield benign results, and perhaps adopt, globally and in the West, risk stratified screening approaches using risk prediction models. Other challenges are cultural norms, and these are not to be discounted by any means. I know, we talk about cultural humility, and I think we all try in the healthcare field and as individuals and just people to sort of be humble about, not thinking that our way is the right way, because we know that's not true. My time traveling in the world taught me, continues to teach me, when I originally went through the Eisenhower Fellowships, the idea was, what can I bring to different parts of the world, to different, sort of remote regions, and I took back from it so much more than I could possibly bring in terms of the care of the patient, the impact of the community, and the importance of that support. So really, in terms of cultural norms, it's understanding risk factors and discussing them in a way that makes sense, and understanding the disease and discussing that in a way that makes sense as well. Lifestyle choices, we can't, there's no way to sort of push one's efforts into, what diet is available, what people have grown up and, sort of historically and familially enjoyed. I think about myself, I try to eat healthy, but when we have, holidays that my mother and my grandmother used to make, we will still eat the same fatty, food that, perhaps we shouldn't. And, and my spouse will say, perhaps we should consider vegetarian or vegan options. But, my culture is such that, meat's a big part of my upbringing and how I grew up, and it's hard to move away from that. The responses to not only, being told, in the United States, we talk about and teach residents how to communicate difficult results. But it's really just communicating even before that. It's sort of, understand the emotional responses, people who are highly emotional or less emotional, how they think about things, how they process things, what it means socially to have, to be told that you need a biopsy or that you need certain treatments. There's a tremendous absence of biomedical terminology in local languages. When we have days where people are coming, Spanish speaking, days to sort of make sure that we serve populations and we bring in translators, that's relatively easy in the United States, most languages. But when you're talking about, languages that are less commonly spoken, even within, a particular country, there's no way to discuss exactly what is being offered and what is happening in a truly meaningful and understandable way. Gender inequality is a major issue, especially with breast cancer. This is a disease that, not solely but primarily affects women, and depending on where you are, there's perhaps lack of resources and lack of options for sort of advocating for women's health. The prevailing influence of traditional health practitioners, having sort of discussed, there are parts of Africa where friends of mine have done a lot of work and sort of come up against really, traditional practitioners, whether it's sort of witch doctors, I guess would be the American terminology, or my time in Mongolia, working with shamans and discussing, their approach. If someone has a mass in their breast, what they recommend, and it has to do with diet, it has to do with prayer. There's so many things that have been driving the care of patients for generations. And I think that part of that is because for so many years, if you sort of look historically from a long perspective, thousands of years, people didn't live past 50. People, didn't live past 60 in general. So these diseases that tend to affect people because of age were just not something that one needed to deal with. So you could, use certain medicinal or local medicinal practices to manage things well enough. And if a patient died, that was sort of the normal course of events, perhaps. I think we are obviously in a very different place. And how do we address those kind of entrenched issues carefully, kindly, and appropriately? And then once again, just the need to incorporate indigenous languages and indigenous practices is key. So some of my work has taken me to be a part of work in Haiti. Right now, unfortunately, because of what's going on in Haiti, that has been at a bit of a standstill for those of you who have been following the news about Haiti. Partners in Health, Paul Farmer, who, may his memory be for a blessing, and Jim Kim, and Ophelia and Tom White, sort of started this organization. And it's an incredible organization that has done not just in Haiti, but in multiple parts of the world. But they brought this concept of providing medical, social, and economic support to people that is sort of run or provided by community health workers. The idea being, and I think we have all agreed to this, that Penn, for example, can come in and set up a clinic and even bring medicines, but if it's only Penn doing it and Penn decides to leave, then there's nothing left behind. So it has to be integrated within the community, within the government, and sort of a shared responsibility between all of us to make things work well. Initially, and now there's skepticism from global health experts in what we can do in Haiti and policymakers. But the idea with Partners in Health was walking with the patient, accompanying them, not sort of doing it from the front or from the back, but being at their side and working together to form a reasonable solution. And I guess unless I borrowed this exactly from the Partners in Health website, but empowering, not enabling. So Partners in Health has done a lot of work, and the folks that I've been working with in Haiti are doing that same work. They train within the Partners in Health model, and the stories that they shared about how difficult it is for an individual who wants treatment, understands that they need treatment, to get the appropriate treatment if they live in a more rural area and they're not in Port-au-Prince. It's not easy work, but we're slowly, hopefully, going to get back in there and provide not just technology, but once again the partnership and the collaboration to make an impact in women's health there. Within the cultural norms concept that we, like I said, encounter in Haiti, where there are approaches to treating breast disease and lumps and changes of all sorts. There was a study done, Journal Behavioral Medicine, back in 2017, looking at the prevalence of cultural beliefs among Latina breast cancer patients. And the biggest one, almost half of all the patients believe that believing God will protect you from breast cancer. I will say on a personal note, I believe that as well. I believe that prayer and faith is a very important part of the treatment. I think that often we as medical professionals come in and discount anything that's not sort of our traditional proven technology, but I think all of it matters. I think all of it matters for one's health. Obviously prayer can't necessarily make a breast cancer disappear, but it can improve your immune system, it can improve your well-being and allow you to sort of be stronger to fight whatever you are fighting, and if you're getting treatment, to sort of empower you to do it even better. And you can see from this list, there are quite a number of beliefs that, depending where you're from, sort of seem outlandish, but yet completely appropriate. So what opportunities do we have? We need to have population health initiatives. Population health has become a very popular word in hospital systems. And really, it's, the health outcomes of a group of individuals is, what we look at as population health, whether it's local, regional, or international. And it's, the distribution of such outcomes within the group, and also patterns of health determinants. And it's making policies and interventions for how we can impact all of this. And that's where population health fits in. Within radiology, it's, we have the ability, I have been a radiologist my entire career, obviously, and I'm very proud. I enjoy what I do. I think radiology for many years wasn't really fitting into population health, or many aspects. We were sort of seen as consultants and just providing diagnoses. But in my training and in the way that we train, we're looking at it as a much larger perspective of bringing radiology into every aspect of the cancer center, every aspect of the conversation, and training our physicians to be the first line for having conversations with patients. So where radiology fits in is, the ability to advise other doctors through a range of services, perhaps acting as a gatekeeper of what additional imaging is and isn't necessary, not always just sort of saying more is more. Assuming a sense of responsibility for surveillance of diseases. We have taken that on very well in breast. We're trying to do more of that with thyroid disease, with low dose screening for lung cancer, with DEXA, bone mineral density, sort of saying that not just performing the studies, but really sort of assuming a role in how we can survey, the patients and appropriately bring in patients for these studies, helping to direct decision support systems, overseeing implementation of, any kind of clinical decision support systems as, appropriate, applying our background in analytics, which is, a big part of what radiology does. It's, interpreting images, but it's also a lot of analytics, a lot of physics, to enterprise level. And so where that can lead is improving patient health overall, perhaps reducing inpatient stays if they need to be hospitalized, and reducing the need for procedures. And sort of next level, providing a sense of holistic care for the entire population, of a country perhaps, but really of any kind of entire population. What population health also means is just doing more with less, and how do we do that well? A big place that we're looking into doing more with less is our AI, like deep learning, both within the U.S. and also globally, especially in breast cancer. There are a tremendous number of companies out there doing some good work, looking at sort of identifying normal mammograms, and perhaps that can be a part of what we can do, so you don't need a physician to interpret every single mammogram. I teach the residents, the truth is, if you're just looking at mammograms and you're looking at them pretty well, the expected cancer detection rate would be maybe 4 or 5 per 1,000 patients. So, some people will joke that they can easily develop an AI tool, call everything normal, and they're correct 99.5% of the time, which, obviously tongue in cheek, but the truth is that, most of the mammograms that we interpret are normal, and yet our callback rates can range from 5%, hopefully under 10%, but there are people who are 15%. So we are doing more work than necessary, subjecting patients to more imaging than they need, when the end result remains the same, that it's just a, breast cancer, while prevalent, is, it's we don't have to overthink things. We don't have to sort of overwork ourselves. So we really need to do more with less. This was beautifully, I think, touched upon by Jim Rawson, who was the president of RSNA, Radiologic Society of North America, I guess the biggest radiology meeting in the world each year, happens right after Thanksgiving in America. And in 2020, in the midst of COVID, his words were, if you wanted to impact the health of the population, if you wanted to have the broadest reach, you'd want to be working with the specialty that has the most contact with patients, and that's radiology. So there are a lot of present initiatives out there. World Health Organization obviously is a leader in all of this. WHO does a tremendous amount. The World Bank has program harmonization for health in Africa. Global Health Corps, RADAID is a radiology group that was founded that does a tremendous amount of work globally as well. Ben Anderson and his group at University of Washington, the Breast Health Global Initiative. Kristen DeSteger out of Vermont has Imaging the World, Doctors Without Borders, Phillips Foundation, tons of foundations, Millennium Challenge work. I think that was started under Bush. And when, once again, having done quite a bit of work in Mongolia, when I was in Mongolia, seeing the impact of that, of the technology that was placed, that was the same technology that we have at Penn and Pennsylvania Hospital. In remote parts of Mongolia. I'm not even just talking about Ulaanbaatar, but even remote parts of Mongolia, allowing the same care to be provided in theory. So WHO has a breast cancer initiative, the Global Breast Cancer Initiative. Its goal, as I mentioned, is to reduce global breast cancer mortality by 2.5%, which would avert about a quarter of breast cancer deaths by 2030 and avert about 40% by 2040. The three pillars of this are health promotion for early diagnosis, timely diagnosis, and comprehensive breast cancer management. So breast cancer rates, once again, we are seeing, highest in the West. These are each standardized per 100,000. But these numbers are growing. This is from a few years ago, and I think, I was not able to find something from 2022, but this, I think, will probably be in the same order, perhaps. Belgium has historically had a very, very high breast cancer rate, but I think these numbers are continuing to grow globally. Major opportunity is, sort of how do we deal and address underserved communities at all economic levels. We need effective strategies, and we need to deploy scarce resources to ensure access to timely, effective, and affordable healthcare. One of the things we're doing here at Penn is mobile mammography, and the idea behind that is just basically a van that we can drive anywhere within the region. Within Philadelphia, where I practice, we have healthcare deserts just like they do in Bainulgi in Mongolia, where people don't have access to adequate care and adequate screening for anything, let alone breast cancer. So bringing it to them. But I think the important thing is that this is a possibility to do, not just in Philadelphia, but throughout the world. To drive out to different regions, drive out, to different towns and villages, and perform mammography and bring it back to perhaps to a centralized reading station, so that we're not looking to staff radiologists or other physicians in areas that it might not be necessary, and do it consistently. I think often what happens is there are mobile mammography programs out there globally and nationally in the U.S. However, they are one-off programs. They go to one site one time, or they go to a health clinic or a health fair, and they don't show up again. The key is to provide the same level of care that you would get if you were to come into the hospital. So if the van goes to a certain town on the first week of October in 2022, and they go to the same town in 2023 or 2024 if globally you're doing biannual care. So there's appropriate follow-up, and their relationships can be made and really building community. I think the key is, COVID showed us the need to build community and trust that otherwise has not and won't exist. Other ways are international conferences like this, like what Health for the World does. It's incredibly important, connecting with partners, expanding the communication, open lines of communication, and open ways of learning, sharing. None of this should be, none of this information should be owned by any individual. So there should be the ability to discuss and to share and to collaborate on research, to share results. The key thing, once again, is asking, not imposing. What do you need? As I mentioned, the work with pit toilets. I think the efforts that were first, and Yulgarel, who was the founder of that initiative, will tell the story that when she first started her practice of doing that work, they would go into a region and say, "Here, we have a great brand new system for you, wonderful, take it." And they found that it was just not used because it wasn't actually what the community needed or wanted. They needed something, but it wasn't what they were being given. So, just slowing down and saying, like, what will work and how does this work? Just sharing connections, and also just visiting, in both ways, like trying to find ways to bring people to the US or to Europe, and trying to find ways to send people from the US or to Europe abroad, and it's not, I sort of use US and Europe because that's sort of, I guess, my perspective as a dual citizen of Ireland and the United States, but it can be the same thing whether it's Mongolia and Japan or Japan and Australia. Just sort of, who has information and access and sharing it in both directions. A major effort that Penn has had has been in Vietnam. Unlike a lot of the other work that I've done, this is actually driven through an actual initiative where Vingroup and Penn made an alliance involving VinMec International Hospital for creating a medical school and resident training program, and basically creating a center of excellence equivalent to what we do in the United States, through the American College of Radiology, MQSA, and sort of ensuring the same sort of expectations of professional quality, sharing strategies and action plans, promoting advancing clinical services, and treatment plans, and just improving quality overall. But even within this shared construct, sort of understanding the differences, whole breast ultrasound is something that we do a bit of in the United States, but not a lot. In Vietnam, it's standard for just about every patient to receive a whole breast ultrasound. I remember there was a conversation I was not part of, but heard about, of the US side saying you need to decrease the whole breast ultrasounds. That's not sort of the standard of care in the United States, and the response being that's sort of a non-starter. Like whole breast ultrasound is, a very, very valuable and important part of our care of patients. Not all patients want to get a mammogram because of the radiation. MRI is not an option in most of the world, even though, perhaps that's the single best study for diagnosing cancer early, as demonstrated by many people, most notably Christian Kuhl out of Germany. So it's a little bit of we agree to disagree, and let's still move forward sort of arm in arm to kind of make things better as we can. So what it showed us was, opportunities to fundamentally strengthen healthcare systems and hospitals, deliver treatments already known to work. I think that's the biggest issue that I don't have a great answer for. I have ideas on how we can diagnose breast cancer, but how do we provide the support once a cancer is diagnosed? I have thoughts on that as well, that are radiology driven. One that we're doing here is cryoablation. It's studies are showing that for cancers under 2 centimeters, it is a very effective treatment for breast cancer. It's a small device. It doesn't need a lot. I think the gas is an issue, but companies are working on sort of a self-contained system, so it doesn't need sort of surgical expertise, and perhaps that's one additional way to address things. having reliable referral pathways. I say primary care facilities, but it's not even that. It's just from healthcare workers, from clinics, and villages, so knowing how they can get folks to the next level hospitals and perhaps to the equivalent tertiary care centers. And I think the opportunity for breast cancer is because there's a lot of interest and perhaps money even supporting it and passion about it because of for many, many reasons. It can serve as an index disease. Things that we can accomplish successfully with breast cancer can be applied to other diseases, mostly non-communicable, but perhaps even communicable diseases. Cervical cancer is a good example. Perhaps ovarian cancer, thyroid cancer, and many other cancers. If we can get it right with breast cancer, we can continue to move forward. Just a few more minutes, and I know there are a number of questions. I will hopefully have plenty of time to answer those. So there are sort of groups that are promoting this work. The California Breast Cancer Research Program is a prize competition for generating ideas. And it's anything from environmental exposures to education, and sort of one of those innovative ways of finding solutions through kind of groupthink and collaboration of minds. Pre-recorded lectures, RSNA has lots of cases that are available as point of care tools. Conferences, the benefit of virtual conferences is amazing, that I think we didn't necessarily all go to prior to COVID, but now I think we very much realize how wonderful they are. Providing the ability for second reads and consultations, places, if we're talking about the breast MRI, and if you're offering it but don't necessarily feel that you have the staff to do it well in terms of interpretation, relying on your sort of colleagues to do it in a way that's not sort of cost prohibitive. Sustaining relationships, as I mentioned, artificial intelligence, and just IT in general. And then, just, technology overall. I think the technology is getting better. It's costly, there's upkeep required, but perhaps we are going to start getting to that next level of kind of over the mountain of it becoming less costly and more easily to distribute. Global health, is, I think, what we're all here about. Looking at the health of populations in a worldwide context that transcend national borders. This is not a single country's problem. Any of these issues, whether it's communicable or non-communicable diseases, these are all of our problems, and we have to work together. I think we saw the tremendous success of that with COVID vaccines, of everyone sort of stopping and saying this is an absolute emergency, so we're all going to work together, and how quickly do we get there to get vaccines available, and I hope and think right, and moving forward, allowing the world to open up again, to reduce disparities, to just improve the health worldwide, and sort of another passion of mine, perhaps and this is a very hopeful, lofty aspiration, but impacting peace in regions that are lacking peace. And I think healthcare is a way, very much, I think music is probably the other, but healthcare is a way that we can transcend differences, because truthfully, all of us just want our children and our loved ones to be healthy and safe, regardless of differences in religion and ideas. And perhaps this is one of those ways that we can move forward. The device that I mentioned also about pre-screening, which is something that is being distributed globally, is this little iBreast exam device. It's a handheld device for identifying non-palpable breast lesions using this piezoelectric technology, where it measures breast stiffness and has shown really strong results for identifying as good as, if not better than, a professional clinical breast exam, and essentially triaging patients who might not go for screening mammogram because there is no mammogram screening program, but could go for a diagnostic mammogram because something is found. And that is it. So I leave you with a quote from Albert Schweitzer, perhaps a controversial figure who did a lot of health work in Africa, but many of his sayings actually are very appropriate, very sort of big part of sort of how I grew up. My mother, who was a refugee to the United States, she was a big fan of Albert Schweitzer's. So I now want to open it up to any questions I can answer. I can take a look unless someone else wants to.
Very good. Thank you, Dr. Englander, for such an excellent talk and for sharing your experiences in global health and for sharing what opportunities and challenges we might face when we start to work towards global health. It's so important to develop these collaborations and to understand the cultural norms before we start these projects. I see that there's a lot of engagement and interest among the audience. And one of the questions was, how does radiology have the most contact with patients when there are a whole lot of countries without a radiologist, which essentially means that places where there is a lack of radiologists, or so how can physicians or other physicians could come into to contribute to early diagnosis or prevention of breast cancers?
It's a great question, and thank you, because I think I'm very much, I speak from a radiologist perspective in that, and perhaps like a America-centric perspective of, we certainly don't have enough radiologists, but there are countries, I don't know that there are countries that have no radiologists, but not a lot of radiologists. So, I will give you an example, my time in Bayanulgi, which is the westernmost province of Mongolia, just sort of touching, kind of not actually bordering, but touching Kazakhstan. They have maybe one or two radiologists. They're not doing screening mammography, obviously. They have a CAT scan and an ultrasound machine. Appointments aren't made. There's sort of people show up and get the imaging. I think that the goal is that, unfortunately, sort of for a disease like breast cancer and for many other diseases, radiology is a part of it. So the key is, how do we get the equipment into places that don't have it? And then how do we provide radiologic support for interpretation of those images? I guess the answer would be, we have done a number of initiatives here in Philadelphia for mobile mammography serving underserved patients at no cost. And there has been a tremendous amount of passion for this and excitement to sort of provide no cost, no cost for the interpretation, no cost for the study itself. But I think places that have, a relative wealth of radiologists, this is not just as I said, this is not a national problem. This is sort of a global problem. It's a global health issue. So I think we need to sort of convince people to step forward and say, like, I will participate in interpreting images if no one else is available. I think the other thing will be AI. These AI companies that obviously are looking to make money, because that's what businesses do, are also looking at solutions for lack of radiologists and providing interpretations that sort of the complicated interpretations can then be turfed to perhaps an individual. And I say this, sort of carefully, because there are some radiologists sort of fear AI is going to replace our role. Like, what do we need a doctor for if we have artificial intelligence? I don't think that's sort of what I'm saying or what is going to happen. It's really just going to provide the ability to take care of more patients and sort of perhaps sort of decrease the burden on an underrepresented group of physicians. There aren't enough physicians anywhere, I guess, truthfully. So I think that is sort of the ultimate question of how do we sort of do it. And I think, unfortunately, it's country by country, depending on the issue and depending on the problem.
True. We also have other questions. One of the question is from Dr. Azari, and he's the CEO of South Asia Center for Medical Physics and Cancer Research at Alo Buhan Trust in Bangladesh. So they are working on solutions for prevention of breast cancer and cervical cancer in rural areas, and they're facing a lot of difficulties in order to have radiologists and skilled technicians. I think it's more or less, it's similar to the previous question. So what is your opinion to kind of overcome it? I guess you already touched upon it a little bit on how can we, improve.
Yeah, no, I did, but I think it's also sharing. So, I'm working right now and sort of helping to create a curriculum for radiology in Rwanda at the University of Global Health Equity. I guess it's in Butaro. And, what we're doing is I'm asking, and, the first curriculum will go into effect, if all goes well this February. So I don't know if that's going to happen this February, perhaps next February, to have people volunteering their time, to have not, often residents would love to volunteer their time, but I guess from a health equity perspective, and I guess I'm a purist on this, that's not necessarily what we want to sort of share, that residents are good enough in one country but not good, they aren't quite good enough in the US. So I also have a number of attendings that want to go over and how we can continue to build on this. I think the issue is cost. Flying people back and forth throughout the world is not inexpensive, but trying to perhaps we can do, and this is sort of my mobile market, I'm rambling perhaps, trying to work within and outside of the healthcare community, trying to work with airlines, which I'm doing for flights from here to Rwanda, seeing if we can get discounts essentially. Like, this is not people just traveling because they want to see the gorillas in the mist, that Rwanda is famous for lots of Western travelers. But these are folks that are actually going in and have a mission and a reason for being in Rwanda that is helping selfishly the attendings and the residents learn and grow, but also helping a group of people that don't have access to the same radiology training.
True, that's right. On a similar,
Dr. Englander, I have a question. I wanted to just follow up on that, if you wouldn't mind. I'm sorry. And that is the role of machine learning, which has been most involved in breast detection for quite some time. And you made, I think, a very good point in that, most mammograms are normal, and so you're going to have a very low, positivity rate. The question I would ask you is, in those perhaps underserved areas that are struggling without radiologic expertise, is there a role currently for any of the machine learning or AI algorithms that you can see right now? And what is the general, it would seem to me that false negative rate would be the most important. That is, you don't want to miss cancers. You certainly, if you had a few radiologists, you'd like to reduce the number of normals that they have to look at in order to see the cancers. So what is the false negative rate in some of these programs?
So machine, they're almost there. From what I'm seeing, we're pretty close. We're using AI as a sort of adjunct. We use computed aided detection. Now we have an AI product in our breast center, and I'm sort of closely monitoring some of the pickups that it makes. I've seen some false negatives. I've also seen some perhaps unnecessary false positives. So that's, I think, until they can kind of get rid of some of those, it's not ideal. But I think we are pretty close to sort of having the ability to, assuming countries are willing to try this, to get it into different parts of the world. Working in the US, as we all know, I think it's going to be many, many years before it sort of has any kind of role in that, because just sort of proving that it's adequate to a sort of human interpretation is going to take a while, and the amount of data that's going to be needed. In terms of false negatives, it's not that different than looking at our own false negatives. It's not that different. It's not that actually much. It's close, the false negative rate, I guess. I mean the false, the false negative rate. It's close. It's probably 1 or 2 per 1,000 higher than we typically would want to see right now. So I think, but that's not completely out of range. We know that we miss cancers, or that, I guess the lawyers tell us that we know that we miss cancers. Whether they really are missed cancers or not is always up for interpretation. So I think, you will probably see within the next 2 years a reasonable product out there that can be placed globally for this purpose of kind of weeding out the normals, essentially. Mm-hmm. So at least, you would need fewer people to interpret the abnormals.
Thank you.
I know there was a question about the role of ultrasound for breast screening as well.
Yes.
That I can touch on, because that's we do a decent amount of ultrasound for breast screening. I think ultrasound actually has a very, very important role. I think ultrasound is one of those technologies. I trained at Jefferson as my training, and one of my mentor was Barry Goldberg, who I think essentially invented ultrasound back in his day and did a lot of work with the World Health Organization. Sort of inspired me to do what I'm doing now. And his whole thing was ultrasound so easy to get into communities, and that was before we have the butterfly and all these small, really inexpensive systems. In the US, it's people don't like ultrasound for screening, even for secondary screening. There's a lot of pushback against it, but I think certainly in Asia, the studies have shown that ultrasound for screening is highly effective. It has to do with sort of body mass and density of breast tissue that impacts that. I think, the larger the breast, it obviously makes it a lot harder. But if that's all that we have, then I think we are doing a disservice globally to say doesn't have a role. I think it's just much more easy to get in there. When you're talking about countries that have inconsistent electricity, mammography is not so bad. Like, obviously you can't place an MRI system into a country that has inconsistent electricity, because if you lose electricity and the MR goes down, that's a huge issue. With ultrasound, you don't need consistent electricity. You just need enough to kind of charge it, and you can use it for the day. So I think we need to really think in a way, as I mentioned, like in our experience with Vietnam, of what's good in the US and maybe proven in the US is not necessarily good or provable in the rest of the world. And I think the US is not necessarily the best example. The amount of money we're spending on sort of screening and care is out of control. And I don't know how we dial that back, because we are where we are now, because you would basically be telling patients, as we've seen, not once a year mammogram, but you need to come every 2 years, and patients reject that because they have been so entrained in believing that what we've been doing up till now is appropriate.
Yeah, that's very true, especially in countries where ultrasound is already there in practice for other modalities, and then we can directly use it for breast sonography. So that will be very excellent. I can see just one more question, which is based on our previous question. So if there is already an NGO in place in one of these countries and they would like to partner with another NGO who's working more on the breast cancer screening, so do you have any tips or suggestions on how to go about it?
Yeah, so I mean, in this instance, reach out to me directly. I think my email can be provided, or you can certainly Google me. I'm at Pennsylvania Hospital, Penn Medicine, and I can help sort of arrange things. I'm an NGO that I sort of started as well, doing some of this work in other countries. But I think in general, there are universities and individuals looking to partner and looking to collaborate. RadAid is another thing that you can look up and sort of see, what work is being done by RadAid. They have done a very good job of getting into lots of different parts of the world and are always eager to expand what they're doing as well.
Thank you so much, Dr. Englander, for your such a nice lecture and for answering all the questions so well. I believe there was a lot of engagement from the audience and a lot of interest, because this is a very important topic and very important to develop collaborations and more work in this field. So thank you so much. And
My pleasure.
Thank you, Dr. Englander, and we wish everybody a great day. We really appreciate your time and effort in this regard. Appreciate it.
Thank you.
Thank you, everyone, for joining.
Thank you very much.